All right, guys, it is 10 o'clock. We're going to go ahead and get started. I am excited to have a dear friend and colleague joining us today, Dr. Jill T. Johnson. She is professor in the Department of Pharmacy Practice at the University of Arkansas for Medical Sciences College of Pharmacy. Dr. Johnson is a clinical pharmacist and a general internal medicine team member at the University Hospital, and she's been in that position since 2004. She serves as a clinical consultant to the Employee Benefits Division for the pharmacy benefit offered to the state employees and public school employees. She also serves as a member of the Arkansas Medicaid Drug Review Committee to develop and maintain the preferred drug list. She is a member of the UA System Pharmacy Advisory Committee and is a board member of the Arkansas Medicaid Drug Utilization Review Board. Additionally, she serves as a member of the Pharmacy Advisory Committee for a large insurance company that provides pharmacy benefits to self-insured as well as fully insured members. She teaches evidence-based medicine to PharmD students at the UAMS College of Pharmacy and various topics in therapeutics courses. Her interests include applying evidence-based medicine to inform drug formulary selection, as well as population health policy to establish and maintain access to a sustainable pharmacy benefit. This lady, guys, is the guru of evidence-based medicine. I'm excited for you guys to get to meet her now. You will get her later on in your pharmacy school career, and she is just absolutely top-notch and the queen in her area. And so it is my pleasure to introduce to you guys Dr. Jill Johnson. Dr. Johnson, you have co-host abilities. Take it away.
Wow, that was quite a thank you, Lanita. Now, it's hard to live up to that sort of
Not at all.
thing.
Dr. Johnson, I do want to let you know these guys are pretty active in the chat, so keep an eye on the chat too while you're presenting.
How do I get to the chat?
So at the bottom,
got it. Yep. Okay, I'll just keep it up.
Yep, there you go.
Okay, good morning, everybody. I'm happy to be here with you guys, and we are so excited that y'all are here, and I hope that y'all will maintain your enthusiasm. I have never once regretted going to pharmacy school. As hard as it was for me, I was not, gangbusters through pharmacy school. High school and college were easy for me. Pharmacy school was not super easy, but don't let that stop you. It should be a challenge. I mean, it's honestly sort of like learning science and math and a whole other language. And so, the job market's tight. You're going to need to figure out how to differentiate yourself along the way. And sometimes things like managed care pharmacy, which I did not get an interest in during pharmacy school, my interest came far after. So I graduated from U of A, from UAMS pharmacy school in the first PharmD class in 1993. And then I've been on Team 3A. I mean, my whole goal, I wanted to be a clinical pharmacist, and I still am. I've been on Team 3A for 26 years. I love it to this day. I miss this morning going to rounds, and I regrettably, I miss it. The stories are fun to listen to. It's like a puzzle every day. It's fun. It's useful. I feel like I'm helping improve somebody's life. And so it's very fun still. I still love it. But in 2004, I became interested. Let me back up. In 2000, I became interested in evidence-based medicine and went to an EBM certificate program or course at the University of Virginia Medical School in Charlottesville. And I was one of 2 PharmDs in the whole place. And it made sense to me that why aren't we applying evidence to make clinical decisions for individual patients? And so from that point forward, I began, before that even, I was offering a course called Landmark Studies with Dr. Granberry. We were both involved in that course. He left and came back, and now he offers that course. I encourage you to try to sign up for Landmark Trials when you enter your 3rd year. Rave reviews, it's an awesome course. But in 2000, when I came back from Charlottesville, I developed an EBM course that has since become a required course in the P3 year. In 2004, as time goes on, things get drugs get more and more expensive, to the point where some drugs are the prices of really expensive homes. I mean, we're talking mortgage size costs to some of these drugs. And so when I don't really know how much y'all know about insurance, but sometimes whenever you buy health insurance, you buy a fully insured, you pay into a fully insured plan, or you can opt for, depending on your employer may offer you a self-insured plan. There's a couple differences with those types of insurance plans when you're trying to buy health insurance for yourself or your family through your employer, or if you're self-insured, if you're self-employed, you may have to provide insurance to your employees. The difference between fully insured and self-insured is self-insured, you can have a lot more say-so in what you cover and what you don't cover. Fully insured plans usually cover a lot of stuff, but an employer group who's paying the bill for that doesn't have any say-so, and they may be covering some wasteful procedures or drugs or whatever. So a lot of the plans right now are going self-insured because they're not as expensive, and they have more say-so on what they're going to cover. And so then that's passed down to the employees. And so it's a little bit cheaper to pay premiums into a self-insured plan. The problem is, in a self-insured plan, the only money that plan has to pay for insurance claims, like if a premature baby is born into the plan, for that employer, then that can be really expensive that year. And the only money there is to pay that claim are the premiums that they take in that year. And so their premiums can vary a lot from year to year. As opposed to a fully insured plan, like a big Blue Cross Blue Shield plan, their risk is spread all over the country. It's not just limited to that employer who's paying the bills. Okay, so that's the difference. So when I got interested in this, Medicaid's costs were going out of control. And so the College of Pharmacy was hired to create a preferred drug list where they could get supplemental rebates from manufacturers. So they could get some of the money back from the drug manufacturers. That helped to kind of soften the blow to Arkansas Medicaid's bottom line and their solvency. So I don't know if y'all understand the difference. There's a difference between Medicaid and Medicare. Medicaid is largely children, impoverished people. It's what Medicaid covers. You have to make so little money. I mean, it's to qualify to be on Medicaid, you really can't make much money at all. Medicare, we all pay into. And when we turn 65, sometimes younger if you're disabled, but if you're totally healthy, at age 65, you qualify for Medicare. And then at that point, your doctor's offices are paid for, your hospitalizations are paid for, and you can purchase a Part D plan for your drug coverage. And so you don't have to be poor to qualify for Medicare. We will all qualify for Medicare when we reach age 65. And so Medicaid, who covers, we're a pretty poor state. So our Medicaid population is pretty big. It impacts a lot of people. It matters to a lot of people and a lot of people's health. So we started dealing with trying to help Medicaid be more strategic about saving money on their drugs. And we created a preferred drug list. And we managed it from 2004 until about 2015. And they changed vendors. They didn't want to go through us anymore, and more power to them. Hopefully they're still doing well. We want Medicaid to do well because that's all of our tax dollars at work. We really want them to do well. Anyway, long story short, and please interrupt me if you have questions. I'm super happy to answer and stop and answer your questions. I know a lot of people want to be community pharmacists. A lot of people want to be hospital pharmacists. Some other people want to do some other sort of off the beaten path sort of career paths. But you're all going to run into who's paying the bill. And so one way or another, whether you learn it during school or maybe you learn a little bit of it during school, believe me, after you get out of school, you're going to learn this because it's going to be important to your bottom line and how you're getting paid. And it just matters. Because believe me, this was not a very interesting thing to learn about in school. But once you almost have to jump in with both feet to decide you're going to do managed care. If you want to dip your toe in, you're welcome to come to some of our, email me and I'll, bring you along to some of our EBRX P&T meetings. So EBRX is a service arm of the College of Pharmacy, much like the Poison and Control and Drug Information Center. The EBRX is the Evidence-Based Prescription Drug Program, and we contract with different plans in Arkansas and potentially outside of Arkansas to help people manage their drug benefit. On Friday, last Friday, so right now we're the College of Pharmacy's in the middle of doing a self-study that we have to do every 7 years to maintain accreditation. And one of my responsibilities, one of the standards that I'm having to work on is mission and vision and goals of the college. And so I had to get a detail that just this past Friday, the Friday out of the last 7 years. And so I asked about what we've done with EBRX in the last 7 years for just one contract, the state of Arkansas, which is a big contract. And we've saved them, EBRX out of the College of Pharmacy has saved them over $440 million in the last 7 years. So we do have some insight, and it's real important that pharmacists have a role in managed care because we can save self-insured plans a ton of money to be strategic. And so we have a little expertise about how to do it, and our expertise has grown over the years. And so that's kind of partly how I've gotten into it. Okay, so what I want to do is kind of back up, and I'm going to share my screen. Let's see. This PowerPoint presentation I want to share with you. It's not very long. Okay, so this is managed care. What would be your career path as a student? And so, first of all, what is managed care? It's managed care pharmacy focuses on managing medication-specific outcomes in a way that drives down the total cost of care and improves the overall well-being of the patient. As opposed to managing and using your clinical pharmacy skills that you're going to gain over the next 3-4 years, this is more managing populations. And so one decision can affect numbers and numbers of people. Managed care pharmacy organizations cover populations of people. Pharmacists in managed care pharmacy have the ability to impact the care of millions of patients. So we estimate, or AMCP, which is the Academy of Managed Care Pharmacy, says that there's over 18,000 pharmacists right now working for health plans and pharmacy benefit management companies. Those are called PBMs. You may have heard of the term PBM, and it stands for Pharmacy Benefit Management Companies. These pharmacists ensure the pharmacy benefit plan provides individual patients with medications that are clinically appropriate, cost-effective, and delivered through the appropriate channel. By contrast, they try to help put in utilization management to different kinds of drugs that preclude the use of those drugs in clinically inappropriate ways or in ways that are not cost effective. Because the last thing that we want is, say, an expensive drug emerges to market. We want the appropriate patients who stand to gain a benefit from that drug. We want those patients to get the drug. What we don't want, and what we have seen, is a rogue prescriber thinking, well, this drug should work in this disease state that it's not FDA approved for and that there's not good evidence for. but we want to try it. And so then that self-insured insurance plan might get billed for a drug for use in one of their patients that's not even FDA approved for that use, and say there's no evidence for it in that use. That's called investigational use. And we don't want the insurance plans going broke funding the investigational use that the manufacturer should be funding. So that's why utilization management is important to catch these things, because self-insured plans need the money. It's not an endless pot of money. They need to have enough money to pay for the claims that are evidence-based. Okay, so this is super complicated, but let's start. Can y'all see my cursor, my arrow? Anyone?
Yes, ma'am.
Great. Okay. So let's start here with the beneficiary. This means the patient. So you're going to use this red line here, and you're going to pay a premium to buy insurance, say through the payer. The payer's going to most likely be your insurance company. Let's just say, for the sake of argument, this is your employer. So there's going to be money taken out of your check every month to pay your insurance premiums. And for that, you get to go to the doctor and you get prescription drugs. But whenever you go to the doctor, you're going to have to pay a slight copay. It's not the total charge, but you're going to have to pay a fixed copay. Sometimes it's a co-insurance. And then you're going to get that service. You're going to get to go to the doctor, get diagnosed. They're going to give you that service of diagnosing you, and you're going to pay this copayment. And they're probably going to possibly give you a prescription. Well, you're going to take that prescription to the pharmacy, and you're going to pay a copay for your drug, and you're going to go home with the drug and hopefully get better. I'm not really sure why this has prescription going to the provider. The prescription, depending on what the prescription is, the pharmacy may have to call the doctor if the prescription requires a prior authorization before the pharmacy will fill it for you. And so they may have to contact the provider. So that's basically what patients know about the goings on. There's actually a whole lot more. The whole northeast section of this slide is what's kind of behind the curtain. And so what's happened is your employer or the payer has contracted with a PBM to administer this whole drug benefit for them. Because, most employers are into selling clothes or, being a gas station or whatever the case is. They don't know anything about drugs and how to provide drug benefits to their employees. So they hire these companies called PBMs. And the PBM runs the whole show, and they provide the employer who hires them, the payer, they provide reports on here's what your patients are using, here's how much money your patients are charging you this month. And so the payer is getting the premiums from the patient to pay the bills to the PBM. Okay, so the PBM is sort of the central player here. And the PBM has contracts with manufacturers, like the people who make the drugs, like Genentech, Pfizer, Merck, all these different drug manufacturers. And they will negotiate with manufacturers to say, hey, well, we'll put your drug on tier 1, so it'll have a lower copay as opposed to tier 2 or tier 3. And we'll do that if you give us a rebate. What's the best rebate you can give us? And so they negotiate that for preferred placement on the formulary. And for that, the drugs, whenever you buy them at the pharmacy counter, they don't cost as much for the patient. And the PBM, as well as the payer, may get some degree of rebates. So it can be cost savings. It's not always a bad thing. It's a bad thing when the rebates aren't passed on to the payer. It's a bad thing when formulary placement is based on how much money rather than how good are the drugs at reducing suffering and improving health. We want, that's got to be the number one reason.
I did have a question.
Yeah.
So literally exactly what you're talking about is what I've been thinking about. Who regulates this process, the PBMs, what they're approving, what they're denying, whether or not the drugs that they're choosing are the best drug? Who does that?
EBRX.
Oh, it's you.
Yes, no one regulates. No one's in charge of regulating. The way that EBRX works, and we're very unique in that we're interested in doing this. We want to get into the weeds here, and we want to stop the madness on the PBMs maintaining control over this, because bad decisions get made. I mean, I've been involved since 2004 with Medicaid and with the state of Arkansas as their clinical pharmacy consultant, and with my own plan, the University of Arkansas system, in inserting, logic on which drugs should be covered and which ones shouldn't, and where they should be covered, and what PAs should be on them, and what should the criteria be in order to get this drug, because we don't want to get in the way of appropriate use, but we absolutely want to get in the way of inappropriate use. Because I'm paying it, it's a self-insured plan. I'm paying my own money to get health insurance and pharmacy coverage for myself and my kids. My husband has his own plan. He's actually paying into the state of Arkansas employees plan. But for my plan, it's self-insured. I don't want a bunch of wasteful use. I would like for everybody who's paying into this plan, let's not cause our premiums to be increased every single year because of high claims or high drug utilization. And in order to pay those bills, they got to crank up the premiums to the customers or to the beneficiaries. So we get in the way with the PBMs, and it's sometimes hard to get a PBM to work with us because we want to make our own clinical decisions. And whenever you send out a request for proposal, which is an RFP, they might say, we don't want to do business with y'all. So we have found several PBMs that will do business with us. And so when employer groups come to us saying, hey, we need some help on our pharmacy benefit, we will say, well, certain PBMs won't work with us. Caremark will not work with us. CVS Caremark, they have their own business model, and it's driven by rebates. Same is true with Optum. Same is true with Express Scripts. The big three do not want to work with us. If you get a mid-sized PBM, they will allow some custom-made formulary decisions. And those are the ones that we work with, and we've been able to save boatloads of money for employer groups who are self-insured. There's some more to this chart as far as the manufacturers and the deals they make with wholesalers and the deals that pharmacies make with wholesalers. I don't interrupt that flow of work, so I'm not super familiar with this. I'm really familiar with PBMs and payers and providers and the rest of it. So there are ways that pharmacists and pharmacy students can start to learn about what to do with this. This next chart is really just maybe in some cases an easier diagram of the previous one if you want to study it. I don't think you're going to get any exactly, Jenny, that's true. So I'm not going to get into that last diagram. It's simply another diagram of the previous one. So there are some key employers for managed care pharmacies. If maybe you don't want to deal with PBMs, maybe you want to do some other aspect of managing populations rather than managing individual patients. The health plans are one. You can get jobs at Aetna or Blue Cross or United. They employ pharmacists. It's not something that pharmacy students in their P1 years or as they're contemplating going to pharmacy school, they might not think, hey, I want to go work for United Healthcare. That's probably not what you're thinking as a pharmacist. But don't forget that there is a role for pharmacists there, and you may develop into that. You can work for pharmacists for PBMs. MedImpact's one that we are very, that's one of the ones that works with us. Magellan works with people. There are other Optum, CVS, Caremark, Express Scripts, and Prime Therapeutics that all employ pharmacists. Their philosophy is different, but they're totally legit employers, and if you want to go work for them, that is legit and on the up and up. And there are wonderful pharmacists who work there. I've worked with people at CVS Caremark. They were lovely to work with. I really enjoyed it. Their philosophy towards pharmacy benefit is different than mine, but working for them is not a bad thing. And so I don't want you to think that. Pharmaceutical industry. So you could go to work for one of the manufacturers. They employ pharmacists. And in fact, 2 years ago, I had a student who was a P4 student. Cameron Bean is his name. And he just really, I gave this same lecture to his class. He sought me out to do some managed care stuff with EBRX and to attend our one of our P&T meetings. And he ultimately did my EBM elective, my special problems elective during the 3rd year. And it just really rung a bell with him. He really enjoyed it. And he decided that he wanted to be a medical science liaison. It's called an MSL. Some different companies call them different things, but it's not a drug rep. Drug reps don't have to have PharmDs. Drug reps can be communication majors, biology majors, whatever. They're not necessarily pharmacists. But MSLs are usually pharmacists, MDs, PhDs. And so he wanted to be an MSL, and by golly, he did everything he could. And straight out of school, which is unheard of, he was hired by AbbVie, and he is in charge of gastrointestinal biologics. He was moved to Phoenix, Arizona, and he's doing great. So that's another route that you can take.
Did you say it was a medical science liaison? What was the acronym for?
MSL, Medical Science Liaison. They're charged really with not selling a drug. They're the backup. They provide the scientific data to prescribers and to pharmacists. I mean, they contact me all the time wanting to tell me about the latest trial that's emerged or that's been published. And they don't get paid necessarily according to how much drug, how much they move market share of the drug that they make. They get paid, I think, based on how many different relationships they court and that they make and how many presentations they make. It's not about how many minds they change like it is with drug reps. It's not based on market share. Their pay is based more on relationship building and presenting scientific data. And so they want to tell you about their new study that their drug has. And that's all good and well too. It's a perfectly great job. They make tons of money. So
Pre-COVID, did it require quite a bit of travel?
yes, it did. Post-COVID right now, or during COVID, they're not traveling really much at all.
Thank you.
Yeah.
Dr. Johnson?
Yeah.
Just out of curiosity, would you say that this sort of field, would you say that the workforce might be flooded, or how hard is it to get into this field? Because you said your previous student that he was right out of pharmacy school and that was unheard of. I'm just wondering if it's something that usually people have to work up to or what.
Well, I think that you have to have some way in the door and starting early. And there are things that you can do during your 2nd year of pharmacy school. There's some fellowships like through Rutgers University in New Jersey and some other places that they're competitive. But if you make your case, you can be in the running for getting those. And those, there are others, not just Rutgers, but there are other fellowships through AMCP and other organizations that are managed care bent, so that you can sort of start to declare that this is the angle that you want. And then people like companies who are looking for entry level MSLs, you can be competitive for those. So networking is absolutely a large component for MSLs.
And just one more question. You said that to be like a regular drug rep, you don't have to have a Pharm D. To be an MSL, is a Pharm D required?
No, it's not required. Some of them are MDs, some of them are PhDs.
But a doctorate is required.
I mean, I don't know if the job description says that it's required, but everybody who I see who are MSLs are all professionally degreed.
Understand.
Yeah.
Thank you.
I don't know if you have to, but I haven't run across the exception yet. Okay. The next thing is specialty pharmacy providers. So there are specialty pharmacies that deal with the specialty drugs. Specialty drugs are defined in different ways, but one of the easy ways that we define them are if they have a comma in the price tag, they're specialty drugs for a 30-day supply. Right now, there's really nothing emerging to the market that's not. I mean, it's kind of the exception right now that new drugs that are emerging to market are not specialty drugs. There are a few. I mean, there are some new migraine drugs that are not that expensive. They're probably too expensive for what they bring clinically, but anyway, UAMS has a specialty pharmacy. There are other, All Care is a specialty pharmacy run out of Arkadelphia, Arkansas. There are different specialty pharmacies. And the difference is they don't stock like the simvastatins of the world. They stock the Humira of the world, and some other even more expensive drugs that maybe regular pharmacies that spot the map all over the country maybe don't typically keep, because those inventories are super expensive to keep. So there are fewer specialty pharmacies that do specialize in keeping inventories of those more expensive drugs. Okay. Health plans are another opportunity, another career path. The function of health plans is to administer medical and pharmacy benefits. Now, I've been concentrating on pharmacy benefits, but medical benefit, when you buy into, when you're paying premiums, you're getting everything, medical and pharmacy. Of the whole, policy that you're buying, pharmacy is about 25% of the spend. 75% of the spend is medical. So it's way more money goes into caring for you, paying for physicians and paying for your MRIs and your CT scans and your procedures than pharmacy benefits. But pharmacy benefits are getting bigger and bigger now. They can't be ignored. Like I said, we really need for you guys, up and coming pharmacists, to, at least some of you, to differentiate into being managed care, because we don't want people who aren't in the know about what these drugs do and what they can do as far as what the trials have shown. We want that to be we want pharmacists to be involved here. It's important. So for health plans, roles of a pharmacist are listed there. There's a whole list of stuff you can do in a health plan. As an employee, as a pharmacist employee of a health plan, you're not just going to necessarily be, a hospital pharmacist. You can, or a community pharmacist, or a clinical pharmacist. Some of these roles overlap. I mean, I'm a clinical pharmacist, but I'm also a managed care pharmacist. And I think it's important to maintain being a clinical pharmacist so that I can appreciate the recommendations that I make at a population level, that they really do affect individuals and their lives. So I think it's a good way to keep my feet on the ground. For PBMs, the functions that they can do is they can develop, promote, maintain, and integrate pharmacy programs. They develop retail pharmacy networks. That's another thing we didn't talk about, where the PBMs maintain they have, like, an employer group that hires a PBM. The employer group will say, I'm picking you. You have to have at least 85% of the pharmacies on a contract in Arkansas. Otherwise, we're not going to pick you to be our PBM. And so those PBMs have to maintain the pharmacy networks as well. I won't necessarily read all of these things to you, but the roles of a pharmacist in a PBM, you can be in formulary development and management. You could be in rebate contracting. You could be in sales. You could manage disease states, because that's a service that PBMs sell to payers, to say, well, we'll manage all of your people who are getting prescriptions for opiates, and we'll devise a program, or we'll offer them this program that we've created to help minimize the numbers of people who are getting opiates month after month after month. So that's just as an example. There are a lot of other, like hepatitis C. Anybody who's getting a hepatitis C drug for the next 12 weeks, the PBMs will disease manage some of those, or they will offer to sell that service to the employer group. They'll also provide patient and healthcare provider education. If you want it, you have to pay for it. So the pharmaceutical industry, their function is is in product contracting and negotiations, selling, getting that drug on the preferred drug list, on the preferred formulary tier. Also a function is understanding product value and positioning, discussions about formulary placement. They contact me every week wanting to get on, to tell me, to educate me about their drug. They develop treatment algorithms. They do pharmacoeconomic modeling and outcomes research, and they create AMCP product dossiers, which go into, sometimes the PBMs, they always go into the PBM's formulary management discussion. So the roles of a pharmacist within the pharmaceutical industry are medical information services, also MSL, which is what I was talking about, also drug safety, regulatory affairs. There are some rotations that you can do. I know if you want to talk to Octavia DeYoung, who's up here at EBRX, up here, I'm on the 6th floor, on the opposite side from the dean's office. I'm facing Memphis, in case you're wondering where I am. Octavia works across the hall. She did a rotation at the CDC. We also have rotations at the FDA. All of these are rotations you can request if you're interested in doing managed care or anything sort of different. You can do health economics outcomes research if you want to go on and or concurrently get your PharmD and your MS in pharmaceutical evaluation and policy. Our grad school is literally right down the hall, and you can do that concurrently and end up with an MS, a master's degree, or a PhD in pharmaceutical evaluation and policy. And you would be evaluating outcomes research on what do these drugs end up doing for us, that sort of thing. What kind of health benefits do they create? You could be a sales rep, you could be a marketing manager. There's all kinds of different roles. Specialty pharmacy providers, you can see what the function is to deliver those drugs, those specialty drugs. They often have special handling, special administration. They often have, be frozen or, be administered in some special way. The roles of a pharmacist are listed there. Distribution or dispensing, drug utilization review, and other utilization management programs like prior authorization. Also, logistics and operations are roles of pharmacists to help be sure that those drugs don't end up on somebody's porch who's gone on vacation and can't pick it up. And in the meantime, it was at the right temperature when it was delivered. There's just all these logistics with these super expensive drugs that need to be adhered to. Workflow, developing PA programs. That's another prior authorization programs. So what are your opportunities at UAMS? As far as P1s, y'all need to start thinking about this early just so that you don't rule it out. So you can shadow an MSL. You'll have to probably create some relationships and try to figure out and come talk to some people, anywhere, any pharmacists or up here even, how you get in contact with pharmaceutical representatives. Certainly during COVID has made that more difficult, but in some cases you might be able to have a conversation through Zoom with one of them that might, not have happened if we hadn't had pandemic situations. You might shadow a managed care pharmacist. You might go shadow in a specialty pharmacy. We have one here at UAMS. Be sure your APPEs, you can be strategic. You can do an acute care rotation. You do need some clinical skills. You'll understand things better if you have some clinical skills. Blue Cross Blue Shield takes our students. The Poison Control Center down the hall from me takes our students. You can participate in the UAMS Summer Research Program. You can do electives with Landmark Trials or with my EBM Special Problems elective. I will accept 4 students each semester to actually, you'll be participating, working up drugs. You'll get my help, but you're going to be, presenting these drugs to our Pharmacy and Therapeutics Committee. There are other different electives that you can take to improve your research skills, to improve your understanding of epidemiology. Others, you can go to an AMCP meeting. You can take challenging clinical APPEs. Stretch, get out of your comfort zone. Learn stuff that you're not comfortable with. That's going to make you more employable. And one of the things that you need to always be thinking when you're doing your rotations is, I always note this on students who I get on my rotations. I can teach them clinical stuff all day long. I can't teach students everything they ever needed to know about acute care and internal medicine, although our patient population is really broad and it's fun. But you've got to be resourceful and accountable and prompt. Some things that your preceptors really can't teach you, but you've got to bring that with you onto your APPEs. And if you do that, that makes you more employable for your whole life. So I encourage you to treat each of your APPEs and your IPPEs as month-long or however long they last, as far as APPEs go, month-long job interviews, because you're going to need to be creating these relationships. Take advantage of any MTM, medication therapy management opportunities. Go to a pharmacy and therapeutics meeting. I'm a voting member of several different pharmacy and therapeutics meetings. If you need to go to one, email me. You can attend an Arkansas Medicaid DUR board meeting. Those are open to the public. So there's a lot of different things that you can do. When you do these things, you should probably put them on your resume, especially if you're involved in creating a poster or presenting a poster. There are different opportunities, I guess is the point. So let's talk about your 4-year PharmD program. In your P1 year, identify opportunities to fill experience gaps. Explore leadership positions in your student organization. Differentiate yourself. Consider the dual degree program of the PharmD MBA or the PharmD. Now, a lot of the managed care people do have MBAs, but you can get your PharmD concurrently with an MBA at UALR, or your PharmD here at UAMS with your also PharmD PhD in PEP, the Pharmaceutical Evaluation and Policy. There are different things that you can do to beef up your training to differentiate yourself. Be sure and keep your CV up to date. I know your career orientation is about to launch into what should your CV look like? How do you maintain and update your LinkedIn profile or your other, what's the other, not just LinkedIn, there are other platforms that help you connect and know where there are jobs. For your P2 year, seek leadership opportunities. Pursue your IPPEs where you have interests, whether it's PBMs or health plans or whatever. Seek internships or paid positions that are concurrent with your school schedule, or be sure that you apply for those and try to get placed in one of those positions during the summer. In your P3 year, update your CV. If you can work anywhere you can work, pharmacy-wise, be sure you get that on your CV. It can help make school easier for you. Be sure that whenever you send your CV out, always send a cover letter. Explore some residency opportunities and fellowship opportunities. Because sometimes those are paid. Residencies are always paid. Fellowships are sometimes paid. And those are those lend you really good skills. Review and pursue APPE options for managed care rotations if you're interested in this, or if you think you might be. I mean, it's just going to be a 1 month out of your life. You can determine if that's going to be something you really like or you really don't like. Be sure in your P3 year to discuss letters of recommendation for residencies and fellowship applications with possible writers. So that's another reason that you need to consider your APPEs as a month-long interview, because you may have to turn around and ask them for a letter of recommendation. And that's something that you will want to, build that relationship with that preceptor over the month. In the P4 year, complete managed care rotations as necessary and as early as in the year as possible, because you don't want to miss out on opportunities that come up that you want to take advantage of. You might consider attending the AMCP meeting or the residency showcase with AMCP. You can also attend ASHP mid-year during December. Be sure that you complete your residency or fellowship applications timely. And do your homework when interviewing for programs. Know what attracted you to the program. When they say, do you have any questions? Don't say, no, not really. Say, yeah, I do. Because you need to consider that you're interviewing them while they're interviewing you, because you might find out something about them that you're like, I really don't want to go there, or I really want to go there. One of the things that I would tell you, and you'll probably get told this a number of times, is when you're asking for letters of recommendation, it's really nice to, if a student's asking me for 4 letters of recommendation to be sent to 4 different places where they might want to do a residency where they're applying, give me a grid and tell me the address, go to the trouble to find out who I'm supposed to be writing the letter to and their full address. Give me the deadline that it's got to be in by, and give me an addressed, stamped envelope of what for me to send. It ensures, and do this for everybody you ask a letter of recommendation to, because it ensures that there's not going to be any holdups and you're going to not miss the deadline on getting your letters of recommendation in. So I encourage you to do that. And afterwards, send everybody a thank you note who met with you during your residency interview. The super impressive ones that I've seen have, they have personalized stationery. They go to the trouble to make an impression, because every touch point is an impression, and that makes you stand out and maybe be selected for that position, because there are limited numbers of positions. Okay, let's see. There are also non-traditional paths. Right now, y'all are in the traditional path of starting out pharmacy school. So just because you don't decide to do this during pharmacy school doesn't mean that you can't switch gears and get into managed care later. That's what I did. So I didn't do a managed care residency. I did a regular pharmacy practice residency, and then I came to work here. But I sort of did the non-traditional path. But y'all are still in the traditional path, so that's okay. And then there are some resources on the very last slide that you can explore. Just wanted to give those to you. And there's probably others. So just be curious and be resourceful. And then you'll figure out what you like to do and what you don't like to do. What questions do you have?
Thank you for taking the time to answer our questions during the presentation.
Oh, you're welcome.
This one doesn't really.
I have a question. Oh, I'm sorry. I didn't mean to
go,
cut
girl.
you off.
No, go.
Are you sure? I'm sorry.
No, please.
Don't be sorry. Go.
Okay, so it was kind of back towards the beginning when you had the layout and everything. So I saw the part about the wholesale on the side, and you were saying so that you guys don't interfere with that, and that's another way to get drugs to your pharmacy, basically. So since that's not connected to what you guys do, would that be the route? Let's say a pharmacist wanted more holistic products as well on their shelves. Would that be the route to get those types of things?
I honestly don't know. I do know that that pharmacies order their drugs from wholesalers. So if they are wanting to get more holistic stuff, they probably need to check with the wholesaler. It's not something that I'm very familiar with. So I really can't answer your question very well. I'm sorry.
Okay, that's okay.
Okay, so my question was about actually a specific Medicaid policy. And I was wondering if you could tell me what the ideology, if you guys had anything to do with it, or what the ideology behind limiting slots was for Medicaid patients and how 3 and 6 were like determined. Do you know anything about that?
I know a little bit. We did not have anything. That's an Arkansas Medicaid self-preservation thing, and it's age old. They've had it for as long as I can remember. So federally, the law is state Medicaids do not have to offer a drug benefit. So we all need to be aware that Medicaid patients, they don't have to be offered drugs. Arkansas offers one. And so they're trying to manage with the limited resources they have from the state government as well as from the federal government as far as how much money they're given each year. They have to be responsible for that amount of money. And so they just arbitrarily, I think, landed on 3 drugs. And now if you file for an extension of benefits, they can get 6 slots per month. But it's arbitrary, and it's just a financial decision they made.
Okay, so it is like just a self-preservation, literally, because, hey, we would run out of money if we just let everyone get all their prescriptions.
Yes, it's
Okay.
sort of like if you consider insurance for the greater good, they can afford, barely, not really even, to provide 6 drugs. I mean, that's just where they landed.
Well, and I don't know, at some point in time, I feel like it would be easier to do like a set amount of money for each person, like, because some of those drugs could be on the $4 list. So if you're getting like 3 $4 drugs and then you have money left over to get, but I know that is not what you do, but I was just wondering if you did know how it came about to be that number.
Yeah, no, I don't know how.
So
It looks
the
like
chat-
somebody asked the question about some paths are non-traditional. Can you give us some examples of that? Well, mine, in that I'm a clinical pharmacist. I deal with individual patients. That is my love. I love that. And then I developed this interest and saw an unmet need and got in sort of the back door that way. I've never really wanted to be an MSL, although one of our former faculty members left here 2 years ago. She was my counterpart, Dr. Rachel McCaleb, and she went to work for Pfizer, and she is an MSL for their breast cancer segment of their company. And so, yeah, I think I'm over time. So if you guys have any further questions, please feel free to drop by my office or email me.
Thank you so much.
You're welcome.
Thank you.
Anyone else? Okay. Thanks.
Thank you, Dr.
Dr.
Johnson.
White.
I appreciate your time. Thank you very much for being with us. Have a great week, you guys. I'll see you all on Friday. Bye-bye.
Dr. White,
Yes.
I sent you an email. I think it was close to like the beginning of class, maybe.
Okay.
All right. I just wanted to tell you.
Okay. Thank
All right.
you.
Thank you.
All right. Bye-bye.
Bye.